Hello, today we're going to talk about access to healthcare in the American healthcare system. Um, so let's jump in. First, we'll talk about the physician-patient relationship, how that's formed, and the obligation to treat. So let's talk about that formation of the doctor-patient relationship. The nice classical approach that one would hope always happens is that the patient would approach the physician and they would discuss what the patient's condition is, what the patient's expectations are, and the physician would share what his abilities are or her abilities are, and what she would intend to offer, and the patient and the doctor would enter into a nice firm handshake agreement as to that doctor-patient relationship. That doesn't happen very often. The only time that does tend to present itself is in the case of psychiatry, hopefully, or behavioral health, where the providers and the patient talk about what issues are to be dealt with and what is to be offered. Plastic surgery, cosmetic plastic surgery, is often somewhat along those lines of the patient coming to talk about an elective procedure that the surgeon provides what she thinks she can do for the patient, and they enter into an agreement from there. All too often, the situation is a whole lot less deliberate, particularly from the physician side. The common situation is a patient presents to an emergency room. The ED doctor more or less takes all comers, and they enter into the patient-physician relationship. In the ambulatory setting, doctor calls the practice, and I'm sorry, the patient calls the practice, and voila, they get an appointment, and they're in the exam room. Quite often, that means that the doctor-patient relationship has started. As you'll see in your reading, the courts have often been very expansive about when that doctor-patient relationship starts. So let's talk about the obligation to treat. Certainly, there is the question of abandonment, which most physicians dread. As you'll see in your reading, though, abandonment is a strictly construed sort of legal concept that really has to do only with the situation of where a patient refuses to treat a patient or leaves the area and is unavailable to treat the patient. It is not the typical sort of firing of a patient, as we will talk about in some circumstances. Let's talk a little bit about on-call obligations. These have a number of aspects to them that need to be considered. When a physician is on call for a hospital, that physician has agreed with the hospital that she will respond within usually a certain sort of set time period to any calls from the nurses or ED physicians or others who need a particular specialist. Let's say she is a neurosurgeon and she's on call, then she has the obligation to come to attend that patient. The interesting part becomes, while she has an obligation to come and attend to that patient, will she get paid? That patient may not participate in the insurance program that this neurosurgeon is a member of. And with that in mind, it then becomes incumbent upon the physician and the patient to reach an understanding as soon as the emergency passes as to what the terms of payment are going to be and what insurance is available and so forth. Let's talk about hospital care and access to hospital care. That usually comes in best known under the acronym of EMTALA, which again, like many of our acronyms in healthcare, is much abused. Very few people have actually read the EMTALA Act or the regulations that were promulgated as part of it, but they certainly do cite it on a regular basis. So we'll look at that in a little bit more detail. There also is not to be forgotten what's referred to as the Hill-Burton Act. That was an act dating back to the 1950s, I believe, that requires that a hospital provide a certain amount of charity care, regardless of what type of hospital it is, if it receives federal funds. There is almost no hospital in America these days that doesn't receive federal funds. So the Hill-Burton Act is often forgotten, but it's certainly still out there. Let's talk a little bit about EMTALA. We'll talk about some of the basic requirements and key terms of it, some of the buzzwords that you will need to know to be smart in the cocktail circuit here. So let's talk about those. First is someone coming to the emergency department. Usually that is pretty dead obvious, that the patient walks through the doors, is wheeled through the doors of the emergency department, and voila, they are there. The regulations have made that a bit more subtle as to what that means. CMS interprets coming to the emergency department as coming to the hospital campus seeking emergency care. So that may be they wander into your lobby, they wander into your ambulatory care center or your urgent care center if it is part of the hospital campus. And that is another $1 million question, is what is the hospital campus? For those of you who work in an integrated healthcare system, there is your company's name is on a lot of buildings out there, and the issue boils down to, would a reasonable patient believe that this site would be where he or she could obtain emergency care? That usually arises in the situation of an urgent care center, or maybe even a family practice center that advertises that it has walk-in appointments, but it would not apply to a freestanding physical therapy department or a freestanding oncology unit, that sort of thing. If one does present to the emergency department, then there is a requirement by the hospital through its medical staffing to provide an appropriate medical screening exam. And that is certainly defined by why the patient is presenting. What one is looking for is, does this patient have an emergency medical condition? If so, then the patient must be stabilized before they are either discharged or transferred from the hospital. You know, what is the appropriate medical screening exam really is in the eye of the beholder sometimes, but it clearly cannot be conditioned upon whether or not the patient has insurance, which is exactly what EMTALA was trying to nip in the bud, was to avoid the situations of patients being screened by the billing folks as opposed to the medical folks. If one is going to be transferred, the transfer must be because the facility doesn't have the equipment, the personnel, or the expertise to handle whatever the patient's particular condition may be. For example, if a severely burned patient comes into a community hospital, that patient probably needs to be transferred to a dedicated burn unit. If it is a multi-trauma patient that is beyond the skills of the local hospital, they should be transferred. The conditions of that are that the sending hospital, transferring hospital, must contact the receiving hospital. There must be doctor-to-doctor contact. The receiving hospital must document that, in fact, they accepted the patient and that all of the pertinent medical information has been transferred to the receiving hospital. If a transfer takes place without the receiving hospital having accepted that transfer, then that's a violation of EMTALA. And the receiving hospital is under an obligation, just as the sending hospital is, to report that, in fact, that violation has occurred. Let's switch gears and look at the termination of the healthcare relationship. First, we'll look at the physician's situation, and then we'll look at the hospital situation. Termination by a physician is a frequent question that I get of, can I fire this patient? And my advice to doctors is early and often, just like voting in Chicago. The doctors are always concerned about, and quite reasonably, of course, concerned about abandonment. Will they be alleged to have abandoned this patient? That is dependent upon why the patient is seeing the physician. If the patient has an ongoing medical condition that requires ongoing medical care that is not readily available somewhere else, then yes, it could be deemed to be an abandonment if there is an immediate termination. If it is a patient who is receiving medical care for a chronic condition that is readily available in the community, let's say hypertension, diabetes, routine sorts of primary care issues, then the patient can be given a very short time to seek alternative care. Again, it is dependent upon what the condition is, whether there's other care readily available for that condition, and whether there are any extenuating circumstances that may apply. The bottom line is that a physician does have the right to terminate the doctor-patient relationship at any time that she believes that it is not healthy for the patient or for the physician. It is kind of an at-will employment situation. Now, that does not consider the terms of managed care contracts that may be out there that may require some other process be followed. So I always question my doctors. Certainly, yes, you can discharge that patient. However, you need to make sure that you're complying with whatever Anthem or Aetna or whoever your provider is, what their process is. The other question I often get is, do I need to provide a list of other providers who could take care of this patient to the patient? And my response is usually only if you don't like those people. There's no obligation for you to go out and place that patient by any means. It might be a nice service that you would provide, but there is no obligation that you find new health care for that individual. The process that I usually recommend is that a reasonable period of time be provided for primary care folks. I usually suggest 30 days that they send a letter, as is required now by Virginia statute, to the patient and document in their chart that they are terminating the doctor-patient relationship. That letter sets forth as little as possible about the details of why the relationship is being terminated, and that the letter be sent to the patient. Question comes up, should that be sent first class or certified mail? It probably doesn't entirely matter. If you want documentation that the patient actually received it, then yes, you can send it certified. The key is that the patient is given notice that the doctor-patient relationship is being terminated. It could well be that one can do that electronically these days if that's the way that you normally communicate with the patient. The key is that you provide adequate time for that patient to obtain alternative medical care. The reason I suggest that it's always be a short letter and not go into the details of the termination in most cases is because it will only spark further friction between you and the patient, and usually the patients are being discharged for bad behavior by the patient, and part of that is tying up your staff with their demands. Not usually very helpful to articulate that. You might want to articulate the reasons if it is a clear-cut issue such as missing appointments, if it is abusing medications that you've prescribed, or some other sort of clear-cut event. But if it's just that they are an aggravating patient and overly demanding, you may not want to be putting that into your letter. Discharge from or eviction from a hospital is a difficult topic, and you'll see I have a blank screen here. It is fairly a blank topic. Usually, patients can be lured out the door with home health care, with placement into a nursing home, whatever the appropriate disposition is for the patient. But occasionally, you'll have patients who just want to stay. It may be that they are homeless. It may be that they just really like your place. And they will think of all kinds of interesting reasons as to why they ought to stay in your facility. If you are going to be forcing them out, that probably requires a legal process to do that, i.e. more or less an eviction process. That is cumbersome, it's time consuming, it takes days to weeks to accomplish, and so therefore it's usually the least reasonable alternative of how to discharge a patient. Let's shift gears entirely and talk about LEP, which is becoming a much hotter topic these days. or at least it was under the Obama administration. I think OCR, the Office of Civil Rights, is still as gung-ho as it was. It just has a different leader these days. The LEP requires that a healthcare provider, every healthcare provider, undertake an analysis of their practice to determine what reasonable steps they can take to provide language interpretation or translation to patients who may seek their care at any given time. That's not limited to language. In fact, there is a very aggressive deaf lobbying group out there that is very clear, very up to date on the obligation of healthcare providers to be able to provide services to deaf patients. So what does reasonable mean? Well, reasonable means that if you are an integrated healthcare system, you probably have to have Spanish interpreters these days. You have to have the ability to provide linguistic ability in numerous languages, which may be provided by your staff or through on-call interpreters or online services or telephonic services to assist your patients and their families. If you are a solo practitioner in the middle of nowhere that has no non-English speakers, then you probably don't really need to do much of anything. The problem is the in-betweens, and many clients have called me and worked with me over the years where there has been a complaint filed by someone who has limited English proficiency, and then they get subjected to the Office of Civil Rights investigation, which is very gung-ho that you should be able to accommodate these patients no matter how unusual their language, no matter how infrequent you might see such patients. And that is a tremendous burden upon small practices. The good news is there are a number of ways to facilitate that, whether that's through local universities. Medicaid in some states provides for interpreters, will pay for interpreters. In other situations, there may be telephone services that you may use, which would be readily available. There may be staff that are available. What I caution against, and OCR agrees, is the use of family members or friends as translators. Their language abilities may be somewhat limited. It also can certainly impede the openness of the patient with the healthcare provider. Either they may be embarrassed about what they are being asked. The translator might not think that that's something that the healthcare provider needs to know. There's lots of things that those family members or friends can really kind of make the translation difficult. Occasionally, we've even seen situations where there may be a spousal abuse situation going on, and the husband is translating for the wife who may be abused. So that we certainly discourage that. Moving on, that concludes our topic on the access to healthcare in this section. I provide you with this picture because in about a month or two, that's what we'll hopefully be looking at. And I hope you all have a great day.